Welcome. I'm Dr. Jay Bregman, board-certified foot and ankle surgeon. Here I'm drilling a modified chevron-type osteotomy through a tiny incision. I'm using a special elevator to ensure the cut is complete and to release the periosteal and ligamentous attachments around the bone. Now I insert a hemostat into the medullary canal to carefully shift the metatarsal head into its corrected position. Here I'm driving the guide wire into the metatarsal. Precise placement is critical for proper screw fixation. On fluoroscopy, we see the guide wire advancing through the metatarsal in real time, confirming correct trajectory. I'm placing a screw alongside the wire for measurement, selecting the perfect screw length for this patient. Fluoroscopy confirms the wire is just short of the joint, protecting the cartilage from penetration. A second wire is placed for added stability, keeping the correction locked before the definitive screw is driven. Now I'm drilling over the guide wire to create the precise channel for the fixation screw. On fluoroscopy, we see where I'm beginning to drill over the wire, creating the path through the cortical bone. Continuing to advance the drill on fluoroscopy, deepening the channel with each controlled pass. The drill path is progressing perfectly along the guide wire, heading into the cortical purchase zone. Now I'm driving the fixation screw over the guide wire, compressing the osteotomy for a stable correction. One precise, controlled motion through a tiny incision, the screw is advancing beautifully. Fluoroscopy confirms the screw is flush to the bone, well seated, not penetrating the joint. Here clinically, the screw is fully seated. The bunion correction is now rigidly fixed and stable. With the first metatarsal correction complete, I now turn my attention to the proximal phalanx. I'll now perform the Akin osteotomy, a precise cut at the base of the big toe to correct remaining angular deformity. This brief transition marks the shift from the metatarsal correction to the phalangeal correction. Here I'm performing the Akin osteotomy clinically through a small, precise incision at the base of the big toe. The Akin cut is clean and controlled. You can see how minimal the incision is, just a few millimeters wide. On fluoroscopy, the Akin osteotomy is clearly visible, a precise cut through the proximal phalanx. The Akin correction is confirmed on fluoroscopy. The angular deformity of the big toe has been beautifully corrected. Back to the clinical view, the Akin is complete and the toe alignment is already looking excellent. Here I'm showing the corrected foot clinically after the Akin. The big toe is now straight and well aligned. On fluoroscopy, the completed correction looks excellent. However, you can see a medial bony prominence, the pseudo-bunion, that must be addressed. I'm now using a burr to remove the pseudo-bunion, the medial bone prominence that appears after shifting the metatarsal head over. A special rongeur is used to grasp and remove the bone just cut with the burr, smoothing the medial contour. Continuing to refine the medial contour, every piece of excess bone is carefully removed for a clean result. Now I'm addressing the bunion eminence adjacent to the metatarsal head, using the burr to turn it into bone paste for easy removal. Here is the final result. Bunion corrected, second and third metatarsal shortening osteotomies performed, and Morton's neuroma decompressed, all through just 4 tiny incisions. This patient walks tomorrow. No cast, no crutches. Dr. Peter Bregman, Bregman Foot and Ankle, Las Vegas.